We'll start. Well, hello, everyone. My name is Key Park. I'm the Director of Policy and Advocacy at the program in Global Surgery and Social Change at Harvard Medical School. So 20 years ago, in Durban, South Africa, the member states of the UN General Assembly decided to combat racism, racial discrimination, xenophobia, and related intolerance by adopting the Durban Declaration and Program of Action. Today's webinar will examine how racism continues to undermine the chief aim of global health equity, in two distinct ways. One, the undeniable link between race and disparate health outcomes. And two, failure to achieve racial justice within the institution of global health itself. We at the program in Global Surgery and Social Change at Harvard Medical School recognize that we live in a racist world and all play an active and passive roles in perpetuating racism. We believe in being actively anti-racist, and we are proud to host this webinar. Thank you all for joining us today, and a special thanks to all the panelists. Now I will turn it over to our moderator, Batul. Over to you.
Thank you, Dr. Key. Thank you everyone for joining us today in our webinar Challenging the Status Quo, Racial Justice in Global Health. We are thrilled to have everyone participating with us today, from the esteemed speakers to the participants and to everyone who spared this 1 hour of their time to discuss this important topic in global health. As unfortunately in the 21st century, we still need to discuss racism, and we still face it in our everyday life. We live in a time of a global pandemic which brought social and racial injustice and inequality to the forefront of public health. We still saw that equity is still far from being a reality, and we've seen that people were affected from different racial and ethnic minority groups because of COVID-19, putting them at a bigger risk of getting sick or dying from this global pandemic. Today, we'll talk about why we need racial justice and why does it matter as global health advocates and a global health community to discuss this. What do we need to do to reach an equal, inclusive, and diverse global health world without any hint of racism and supremacy? And how can we play our respective roles as part of global health community to achieve that? In the spirit of what Angela Davis once said, you have to act as if it were possible to radically transform the world, and you have to do it all the time. So we are lucky today and thrilled to be joined with an esteemed list of speakers who are global health leaders from different backgrounds, who have been long-standing advocates, influencers, and shapers of the global health agendas in their respective settings. We have lots to hear and learn from their experiences and perspectives on this topic. And they will help us shape the discussion to put forward the challenges we face in reaching racial justice and how we can overcome those challenges. Starting with Manon, if you can share the presentation. Starting with Professor Flavia Senkubuge, who is a medical doctor, public health medicine specialist, and a global public health advocate. Professor Flavia is the incoming Deputy Dean Stakeholders at the Faculty of Health Sciences at the University of Pretoria in South Africa. She is also the first Black woman and the only third woman in 65 years to become the president of the Colleges of Medicine South Africa. She currently holds multiple positions. She is currently the chair of the WHO Afro-Region African Advisory Council on Research and Development, and she is as well the president of Women in Global Health in South Africa. It's a great pleasure to have you with us today, Professor Flavia Senkubuge. We have as well Dr. Rispah Walumbe, who is a global health specialist with a focus on universal health coverage, healthcare financing, and policy. She worked with vulnerable populations in rural and low-income urban areas in Kenya. She's a public health researcher and an advocate for improved access to quality healthcare services through universal health coverage. She has supported, trained, and mentored over 200 healthcare workers across Kenya, and she is currently the health policy advisor for Amref Health Africa headquarters. Thank you so much for joining our panel, Dr. Rispah. We have Dr. Osahon Enabulele, who's the chief consultant, who is a chief consultant family physician. He also has a long-standing history working with professional associations, being the chairman of the Socio-Medical Affairs Committee at the World Medical Association, the president of the Commonwealth Medical Association, and the past president of the Nigerian Medical Association. He's the founder of the Initiative for Citizens' Health and Good Leadership Development. He is a human rights and health advocate and a public health, public affairs and policy analyst. And over the last 2 decades, he committed himself to strengthening healthcare systems, universal health coverage, as well as the rights and autonomy of physicians worldwide. Thank you so much for joining our panel. We have as well Dr. Omnia Al-Umrani, and it's very inspiring to have her with us. She's a global health advocate, a global youth health advocate, and also a plastic, reconstructive, and aesthetic surgical resident from Egypt. She's currently working as the liaison officer for public health issues and the International Federation of Medical Students Associations, representing the voice of more than 1.3 million medical students from 140 countries. She is leading IFMC's external work on areas such as climate change, NCDs, and mental health. And she is also an associate at Women Leaders for Planetary Health. It's a pleasure to have you with us, Omnia. And now I'd like to introduce 2 colleagues of mine from the program in Global Surgery and Social Change. We have Dr. Barnabas Alayande, who's a general surgeon from the with the National Postgraduate Medical College of Nigeria and the senior registrar with the West African College of Surgeons. He serves as a global surgery fellow at the University of Global Health Equity in Rwanda and the chief research fellow with PGSSC. He is passionate about surgical improvisation and contextualized surgery in African settings, and he's currently focused on creating a creative curriculum for low and middle income countries in surgical education. And we have as well Dr. Manon, who has been one of the main organizers for this event, and who's a Belgian orthopedic surgery resident with a passion for global surgery and global health policy. She's also a senior fellow at PGSSC, where she focuses on the cost-effectiveness of hip dysplasia screening in low-income countries, and the development of qualitative tool to assess pandemic preparedness of surgical departments in Southern Africa. She's currently the Socio-Medical Affairs Officer at the Junior Doctors Network at the World Medical Association. So hearing those amazing achievements and experiences of our esteemed panelists, I'm sure you're very excited to hear their thoughts on the matter. So we will start the first thing with Professor Senkubuge. And Professor, can you set the scene for us? Why do we need to discuss racial justice, and how does the resurgence of racism in the 21st century shape geopolitics of global health?
Thank you, Dr. Al-Khwadani, and I want to recognize Dr. Key Park as well. And I really also, distinguished colleagues, good afternoon, good morning, good evening. I'm really flattered and honored to be here this afternoon and share the stage with this distinguished panel. And I must hasten to add a little tidbit that as we talk about racial justice and global health, today in South Africa, we're celebrating what we call Heritage Day, where we celebrate our diversity and cultural wealth. And so in greeting you, I really want to recognize my forefathers and foremothers, the Mandelas, the Nkrumahs, the Nyereres, the Kenyattas, and so many more, because it's through their sacrifice that I'm able to sit here today. And so in answering the question, Dr. Batul, on the resurgence of racism and how it has shaped geopolitics and global health, I really want to say that we first need to ask ourselves about the root. And so we need to ask, is it really a resurgence or is it a revelation? And in essence, I believe, in my mind, that is actually a revelation, because you see racism, discrimination, sexism, apartheid, xenophobia, injustice, they've always been with us, and they still are with us because we have not and we had not really dealt with them. But I believe that we've merely put a plaster or a band-aid on a wound that is in actual fact that needed to be debrided. And I think most of the people on this panel are surgeons, and the surgeons will explain what debridement means, but really it's around really treating a wound. And so the many shocks and the gut-wrenching challenges that we have experienced in recent times as a collective humanity, like the COVID-19 pandemic, have ruthlessly pulled away that plaster and exposed what I call the truth, which is the wound, the gaping, bleeding, untreated wound that has always been there, and that is then in fact a revelation. And as it is then, because the root of racism is fear, it's self-interest and discrimination, it has gone then without say that the zoning or the self-preservation of nations that we currently call geopolitics has followed the, I need to protect my people from them, their diseases, their sorrows, their poverty, their negativity, that narrative. And so I believe, Dr. Batul, that in order for us to have a leadership paradigm and a shift that will achieve racial justice and global health, we need to have true and authentic leadership with heart that really recognizes, that gets, that understands our interconnectedness and our shared humanity, which in Africa we term Ubuntu. I am because we are. And so as a society, we also have a role. And our role as a society is to create the safe spaces for these leaders who are going to lead with Ubuntu. We know a lot of great leaders who have led with Ubuntu, who have led with heart, but we as a society have not created those safe spaces for them to lead. And so we as a society and we as leaders need to create those safe spaces for these leaders who will emerge with these human policies. Because our true commitment, Dr. Batul and colleagues, to racial justice and global health, we demand that it will demand that we build a new architecture that I believe needs to be rooted in Ubuntu. I am because we are, where we truly see, where we truly hear each other. And if we must, we should not be afraid from starting from scratch. And I really believe that we need to boldly do this, because we cannot build on a structure that is not geared for racial justice. And again, I want to repeat myself and say, we must be bold enough to build again and have an architecture that recognizes and does right by our people. And I believe then, and only then, will we begin to achieve true racial justice and global health. Thank you so much.
Thank you so much, Professor Senkubuge, for these very important ideas and for setting the scene for us. So we need to keep in mind that we need a transformation, we need to be bold, and we need to be change makers to create this safe environment for leaders to implement this change, as you have told us. So now we move to Dr. Rispah Walumbe, and you have been a champion for universal health coverage for many years. And from your own experience in building up on what Professor Senkubuge have said, how does racial justice shape global health agendas? For instance, how is universal health coverage affected by racism?
Wow, that's a very heavy question, but thank you so much for having me on the panel. And it's a tall order to speak after Professor Flavia. I think one of the things that's really interesting as we continue to have this conversation is just understanding how policy is shaped generally. And in policy, in our policy speak, we all often talk about political systems, and we talk about power, and we talk about the distribution of that power. So as we know, I think when you look at political systems, I think sometimes we forget that racism is very different from a racial system. And I think those are two different things. And when you look at how racism looks at it from an individual perspective, like how an individual perceives another, based on how one individual perceives someone and values them based off of the color of their skin, or many other things that would make you discriminate against them. But I think the shift in terms of how, when you look at it from a policy perspective, you're looking at it more on the system side. So that means you're looking at political systems and you're looking at policy systems that kind of drive our agenda and how global health is shaped. But just on the tail end of what Prof. Flavia said, that if you look at the root of global health, the global health architecture, its roots are actually in colonialism, right? So you look at how we started off with colonial medicine or missionary medicine, right? For my perspective is mostly, I grew up and lived in Africa most of my life. I'm a Kenyan and I live in Kenya currently. And so when you look at how people, like how the process began in terms of how people began to think of global health, it started off with, you know, missionary medicine and a bit of colonial medicine. And it's important to understand that those motivations were not necessarily altruistic, right? It's not that they were coming and trying to make sure that there were systems in place because of making sure that, you know, people were well, or it was, how do we protect ourselves from the diseases that we might get when we come into these new places, right? And so that was inherently built into the design, even though it's shifted quite a bit from what it was then, it still has that, right? And even you look at the conversations for, it used to be universal health coverage versus global health security. You know, when you look at it on a global health landscape and you look at global policy. But in terms of how it's influenced universal health coverage, I think one of the things that I've continued to see is that the debate is always around, you know, how we've set up our health systems as, you know, African nations, that our health systems, there's a very long list of all the things we do wrong, right? And very rarely do we identify the opportunities that there are because of just by nature of who we are to actually make improvements and take strides towards achieving universal health coverage. So I think when it comes to policy and when you look at the history of even universal health coverage itself, there are a lot of policy implications that, a lot of policy direction that actually shifted the goalpost for African countries to achieve universal health coverage right from the inception. So if you look at things like, I think it was in the 80s where we had the structural adjustment programs, which I think is the best example to explain exactly what happened when African countries already had acknowledged the fact that healthcare was a right. It was something that was deserved for all people, right? And here comes a global entity that decided that, no, we're going to shift and we're going to say, I don't think you should make investments in healthcare. You should provide healthcare for free. We're going to shift that post and we're going to tell you, you know, you should instead make investments in infrastructure and things like that, things that will generate funds to fuel the economy. But I think even if you look at it now, COVID-19 has shown us that, well, did you know that when people don't have access to healthcare and people don't have access to good health systems, your economies will shut down, your social systems will shut down. So I think that's something that's really, that's one of the older examples, but it's also now inherently how our structures are defined is because of, you know, all those racial injustices and all the things that we've experienced. So yeah, that's what I have to say.
Thank you so much, Dr. Rispah, for highlighting those policy implications in shaping global health agendas, that it could be a positive shaping in which we can have more advocacy to drive those health agendas for vulnerable populations, but at the same time, it could be a negative one that could slow the agenda itself and divert the focus on those agendas and the access that vulnerable populations have to healthcare worldwide. I'll take this opportunity to remind the participants that feel free to use the chat if you would like to ask any of our panelists any questions. We're going to have 10 minutes in the end for Q&A, but also if we're able to take some few questions here and there, we'll check the chat. So please feel free to post your questions there. And if you would like a certain panelist to answer the question, just please mention them in the question and we'll direct that question to them. So now we move to Dr. Osahon Enabulele, and with a long-standing experience with professional and healthcare organizations at local, regional, and global level. How can organizations and institutions overcome structural hierarchies that exist within themselves? How can they lead by example?
Well, thank you very much. First of all, I need to appreciate the fact that this, for me, is a privilege to represent the World Medical Association on this panel. I appreciate the organizers, and I hope that one would be able to, of course, meet the expectations of this session. I thank you, therefore, for the invitation, and also, like I said, appreciate the WMA that has asked me to represent the body. The first point to note with respect to the questions that you raised is the fact that organizations need to continually and very dynamically do some level of appraisals. The organizations, institutions must brace up to the reality of racism, and of course, structural barriers, if you like, hierarchies within the organization. Because what you see more often than not is some level of denial. Everybody is walking, everybody is relating, but there's a deep-seated, deep-seated biases, which of course relates to personal beliefs. This whole issue of social construct that sees individuals, from physical, trait perspective, and perhaps begins to categorize them into different categories. And of course, that creates some level of supremacy thinking. So organizations must constantly do some level of interrogation, and as part of the strategic envisioning, and be able to unearth some of these biases that of course exist within those organizations, whether they are commercial companies, pure institutional organizations, medical associations, and then embrace this reality, because it has very serious impact on outcomes. Whether talking about organizational outcomes or even health outcomes in the case of medical institutions. So, and I haven't accepted that some level of awareness, therefore, is created, which of course needs to be, built into some level of consensus driving to get everybody to appreciate that, look, this is a reality that needs to be confronted and not avoided. Because avoidance is no good, mechanism for resolving these structural hierarchies and barriers. And of course, you need to get down to the main business of identifying or interrogating the root causes of the problems that exist within those organizations. Because when we talk about structural barriers and hierarchies, or if you like, even racism, whether systemic or otherwise, there are various dimensions and various causes. So it's for the organization to get the best from its workforce, it needs to be able to appreciate the root causes of some of these barriers. Is it at the individual level, at the institutional level, or even at the cultural level? All right. So, are there personal characteristics and attitudes that are giving rise to some of these, problems that have been identified in the workplace? What are the established policies of the institution? I must say that the WMA, for instance, is an organization that has a very flat, is flat when it comes to the issue of hierarchies and barriers and all of that. So, it's a very leading example in terms of how to drive organizations that have zero tolerance for, if you like, systemic racism. So what are those causes? Because you cannot be driving an organization devoid of systemic racism or, systemic racism or structural barriers without identifying those causes. So you now need to move to the next level of, strategizing towards addressing some of these issues. I won't identify those causes. And there are various interventions which largely must be equity driven in terms of equity-based interventions. Because what you are trying to do is to create some level of fairness, some level of sense of belonging for every player within that organization. So you must now therefore look at how to attenuate, or if you like, moderate those personal characteristics and attitudes from the standpoint of the core values of the organization. Because don't forget that every organization has its core values, just as you have personal values. So whatever strategic, plan or strategic solution has to be found, has to have a reference from those core values of the organization. So how do we change even those core values? How do we get institutional policies and practices that inure to, some level of equitable transactions within the organization? So, and I think, like I said before, the World Medical Association is within the health milieu, within the health, space, has has been a very formidable leader in this through ethical policies and principles. For instance, the World Medical Association believes very strongly that there should be medical neutrality in terms of creating access, equitable access to care. And that's why WMA, for instance, promotes the whole concept of universal health coverage. So there are various, policy prescriptions from WMA, that has tried to, of course, not only give awareness to the reality of racism in medicine and healthcare, but also actionable points that can be undertaken to, of course, guide against the promotion of this, very deleterious, concept of racism within the health workplace. For instance, like I said, the Declaration of Geneva, which of course is a very formidable document, enunciated by the World Medical Association. In various paragraphs of the DOG, it talks about the need for instance, to respect the dignity of the patients, the autonomy and the dignity of the patients. If you look at the third paragraph of the Declaration of Geneva. So also the 5th, 7th, 9th, and 12th paragraphs preeminently tries to see how the practice of healthcare can be undertaken, with the elimination of all sorts of discriminatory tendencies, whether racial, social, whether age, sex, all sorts of barriers. So it's doing that because of its concrete belief that racism in medicine and global health is unhelpful. It creates health inequities, it creates disparities in health outcomes, and of course, eventually impacts on population health. So the WMA is a leader in this respect, and it continues to do a lot more to, of course, not only create this level of awareness about the reality, because the WMA acknowledges racism in medicine and racism in global health as a reality, but also finds it very unjust, socially unjust, unethical, and something that needs to be confronted frontally by organizations and by institutions. So I would like to stop here for now by saying that the WMA is very, very, committed towards elimination of all forms of barriers and inequities within the health space, and has done that formidably over the decades. Thank you very much.
Thank you so much, Dr. Enabulele, for this this very thorough explanation of how can global organizations serve as an example, and the different type of policies that, for example, WMA have to combat racism at all levels. To be a global organization in our world nowadays, you have to stand for the true principles of anti-racism to deserve to call yourself a global organization. And global organizations have a lot of impact on their local chapters as well, and they can guide them through addressing those issues at local level as well. So we need to identify those structural challenges, and we need to find the root causes and create policies to address them for such global organizations to serve as an example. Dr. Enabulele, you mentioned that we also need to address and challenge those personal values and attitudes, which sometimes may lead to having different thoughts about racism. And this would lead me to Dr. Barnabas Alayande. And from your experience and your vast interest in creating creative curriculum in medical education, how can we achieve a knowledge shift and build an anti-racist health workforce nowadays?
Thank you so much for the privilege and honor to be here. I'd like to respond from a tension. Racism is not just the HIC or an LMIC issue. And I personally have been in training on both ends of the spectrum, and I've seen it ingrained in the systems that educate us. For instance, I've been personally denied a job at a health institution because of where I was from tacitly. So building an anti-racist workforce begins with education, but that awareness is not an end in itself. So we have to ask ourselves questions like, whose history do we replicate? Whose heroes do we celebrate? Whose legacies do we perpetuate? We must be aware of the past. There must be education about the past, colonialism. That should come to the fore, and we must learn it. And then there's education about the present, that we must work, that this is the way it is. We must come out of denial. As an earlier speaker said, we must be aware of our healthcare stereotypes. things like certain people of a certain race have a low pain threshold. Some people, we must be educated about those things, educated about the health outcomes. And then we must start educating ourselves about the future, that it doesn't always have to be like this, that it's okay to be vulnerable and sit around and you're trepid about talking about it, but still gathering around a safe environment and talking about these issues like we are talking about it right now. So my thoughts are that we need champions. We need healthcare workers who are willing to rock the boat. It's not convenient. And we've moved from calling people out, we've moved to calling them in, literally. So there's a way that we speak up, and we're willing to be the people who point at the elephant in the room. Then organizations need to articulate bold, meaningful, specific goals that lead to actions, not just vague stances or just vague comments or things, that just for the sake of it. Window dressing, Black Lives Matter is out. Okay, let's join on the back, but there's something going on in our world. And then we use it for that window of time when there's a lot of tension and these things are being called. So we're talking about specific, meaningful goals that lead to actions, not just generalizations, a sustained commitment by educators to anti-racism beyond being equal opportunity employers. Then again, we must tie these goals to metrics for healthcare institutions, metrics for health education, for instance, we have a colleague at the program Global Surgery Social Change who is spearheading a work where we're looking at conference equity. These are metrics that are defined, and then we must begin to hold ourselves accountable for them. Hiring to increase sustained diversity that will reflect the population are things we have to think about, and we have to do it fast. Research, health institutions must do research into these things, into racial disparities, and then join on to contribute something or the other. And we must include our patients in this journey, listen to them, and design opportunities. There's an amazing article by Esther Chu that was in the Lancet, where she's talking about 7 things organizations should do to combat racism. And I think that's a good article to read, and somewhere where we can start to draw things to do. Now, for instance, I've worked with the University of Global Health Equity, and I see that health equity training is core, regardless of where you are. That should be in the foundations of education. Humanities training, for instance, as a foundation. These medical students are coming in, we're trying to build a health workforce that is conscious and aware of that. They get training in the humanities, and it's not common, all across board. It's a foundation, and the curriculum is not just cut and paste from somewhere else. Then the program Global Surgery Social Change, we started a couple years ago, ingraining education, racial equity education, anti-racist training into the programs. This is necessary, and this is a direction where I believe that every health education training institution should begin to go. So there are lots of things that we need to do, but I think that we should even be holding leadership accountable and compensating people in education, in healthcare, based on executives, for instance, based on what they're doing to combat racism. So these are a few of my thoughts. Thank you.
Thank you so much, Dr. Barnabas, and thank you for this very important message, which is health equity training and education is core and the foundation for medical education, and we need to have an anti-racist training. As when I was a medical student, I remember, and sorry for stealing this omnia from IFMSA, but I remember that we did a survey for medical students from around the world, and we asked them who was taught about universal health coverage in their schools. And less than 50% mentioned that they heard ever about universal health coverage in their education as medical students. So there are lots of gaps that exist in our education. If this is an example of a global health agenda, which the whole world is talking about, and less than half of the world students are taught about, then I can imagine that health equity and anti-racism is far in the agenda list for universities worldwide. So the important message that you highlighted, we need to hold leadership accountable when it comes to education, because that's how we can form the future health workforce. Going now to my colleague as well, Manon. Manon, from your experience and working in so many global professional organizations, as a young person, as a young professional, and as part of medical associations at local level, how can we achieve equitable institutional diversity for organizations and institutions working in global health?
Thank you, Betul, for that very important question. I think that is the question, a bit the elephant in the room at the moment. How do we do that? I think there are two things that needs to change. One is the institutional way that we approach hiring and how we get people in positions. And I think we need to change our interpersonal relationships as well. Taking a bit of a step back, looking at the past 18 months, I think COVID has really shown us that global health is not only an issue of low and middle income countries, as we are told so many times in high income countries. Like, global health is something for poor countries. No, we were the ones that didn't have the healthcare systems that were capable of addressing the first surges in COVID. We have the governments that are not able to donate enough vaccines to the COVAX system. We are all in this together, and it is the high-income countries, the governments, the researchers, the global health professionals, the young people who aspire a global health career from those high-income countries that need to change their attitudes. And I think the first thing that we need to do is listen. Listen to the people from low and middle-income countries. Listen to the people who are not white. Listen to the people who had those adverse experiences throughout life, and like Barnabas also mentioned, like, have these uncomfortable conversations and learn about how we have to change. Like, I've had many of those uncomfortable conversations with partners, with friends, with even with direct colleagues, and it is unpleasant. It is not nice to hear that the behavior that you express or the way that you start discussions is not the way that it is perceived by people in other cultures or in other countries. But if we don't hear that, we will never change our behavior. And I think the only way that we can move towards a true partnership between high-income countries, low and middle-income countries, between white, brown, black, is by having that mutual respect for each other. And I think that first step needs to come from the high-income countries. So how do we do that in practice in institutions? I think in the Junior Doctors Network, which is essentially the young professional section of the World Medical Association, where Dr. Enabulele works for, I think we have been pretty good in having a very diverse management team. And the way we achieve that is by actively reaching out to people that we think have potential to be on the management team and saying, like, well, let's work together to make sure that you are ready to apply for a position. We also actively invest in capacity building. We organize trainings on policy. We organize training on how to write scientific articles. We really strengthen those very practical skills that people need to be effective in global health. And I think it's a self-reinforcing cycle, because working in such a diverse environment also showed me the strength of all those different cultures, all those different views, which tells me that in the future, I would actually like to continue working in such environments. So I will actively keep fighting for having diverse management teams and diverse leaderships, because I experienced the added value firsthand. And I think also those connections that we now make early on in our lives are the connections that we will leverage for a very, very long time. Those are the people that in 20 years we will call and say, hey, I need this, or can you help me out with that? And I think that the fact that those connections now go beyond our own culture, go beyond our own country, I hope in the long term will actually help to make the institutions that we work for more equitable.
Thank you, Manan, and thank you for reminding us that we need to start early, and we need to start as early as possible to create and foster this environment and to have it continue as long as possible. And you've mentioned having those uncomfortable conversations and actively keep fighting, and all of those inspiring words, which reminds us of the role of young people in shaping global agendas nowadays. We go now to Omnia, and as we say, last but not least, and Omnia, we ask you to set the hope for us and to actually answer the question of the title of our webinar: how can we challenge the status quo? How can young people play an active role in challenging the status quo and shape the equation of racial justice?
Yes, thank you so much for having me. And I think from all the interventions, we can all agree that race is a leading social determinant of health. And as Manon mentioned, with the COVID-19 pandemic, it has made us, as much as it in general has made us step back for the first time in a very long time, it has exposed how our governments, our healthcare systems had many failures to address specifically the racial disparities when it comes to health and healthcare. And as Batul mentioned, we did a survey before, and we always do surveys to ask our medical students about their own education. We held a survey last year, and we had responses from 50 countries. We asked them specifically what extent does their medical curriculum include migrants, refugees, women, racial and ethnic minorities, as well as religious minorities. And we saw that in the general trend in this global scoping review, we saw that more than 70% mentioned that this was not addressed in their curriculum. The only mention of minorities within the medical curriculum was people specifically living with disabilities or people living with HIV. Nevertheless, this means that future healthcare professionals, they are not sufficiently trained to address the intersection between health and race. Our medical curriculum does not prepare us to do that. However, as a federation of medical students from 140 countries, first of all, we've adopted several policies to represent our unanimous stance when it comes to empowering our healthcare students worldwide. We have called on them, and we have dedicated ourselves to stand up and advocate against all diverse forms of racism and racial discrimination. We have also committed to actively advocate for the necessary social change that we need in order to advance equity at the intersection between health and race in our own workplace, in our hospitals, primary healthcare centers, communities, and beyond. For us to do that, we have our policies, but we also have our grassroots activities, which our students have shared with us. For example, in Brazil, our medical students collaborated with traditional doctors of an indigenous population called the Sequana. They have worked with them closely to identify the barriers for accessing the healthcare services that the population needs, and they have specifically focused on the vaccination scheme in the child population. On the other side of the world, in Belgium, students have organized several workshops in summer schools that specifically focused on reproductive and maternal health, but they had a specific lens. They wanted to invite students from all diverse disciplines, from law, from arts, psychology, political science, and health. And at the same time, they focused on the non-discriminatory access to maternal healthcare services. And then finally, and this is inspired by what Dr. Alayande has said, our medical students in Sudan, they are working closely with their universities to design frameworks that focus on and promote health equity, cultural safety, and racial injustice as a key component of medical education. On a global level, and IFMSA as well, we have consistently organized open space discussions with our medical students, calling on them and discussing with them the resources and the means by which they can be involved in the fight against structural racism and racial discrimination. And at the same time, we have collaborated with diverse partners like the Lancet, the UN Relief and Works Agency, the WHO, to hold virtual events to discuss more how medical students can be involved, especially in the light of the recent Palestinian crisis. We have talked also and discussed how the refugees and the migrants from the Palestinian population, how we can address and serve to their urgent as well as essential healthcare services that they need. Finally, and I want to end my intervention with an invitation to all the panelists, to all the participants of the webinar to work with us. We are the future health workforce. We are young leaders, and we don't just want youth from the health sector, but we want youth from diverse disciplines to work with us to build a sustainable culture of inclusion, diversity that promotes health equity and racial justice at its core, not just for us, the current future health workforce, but for the future generations to come. Thank you, and looking forward to your questions.
Thank you so much, Omnia, for giving us this great dose of optimism and hope, and for showing us that young people not only have already done it, but are also doing it. And I, as always say, if the world functions as IFMSA, we would have a better place to live in. Thank you so much for our panelists. We can open now the floor for questions, and I can see on the chat that we have a question from Jenny Lindberg. So I'm just gonna read the question, and if any one of the panelists would like to answer this question, please go ahead and answer it. So the question is, what is your opinion on international adoption of children with special needs, cleft lip and palate, from developing countries because of lack of national healthcare resources to countries with more resources? This could be generating inequalities and does not drive the national healthcare system to further development. Is this a problem, or should you think about the individual children you help through these adoptions? Does anyone from the panelists would like to answer that? So I think, as I understood the question, what's the opinion about having the treatment, I think, of cleft lip and palate children in high-income countries instead of driving change in the systems of those countries to further develop, to address this issue? Yes, Omnia?
Yes, I think this is a very interesting question. I have personally seen it in my own hospital, where we had several cases, especially children with cleft lip and palate come from different countries in Africa, for example. And I see that this is a perfect example of the needed cooperation that we should have. So, and this is an issue that we always, for example, talk a lot about when it comes to, for example, climate change and diverse global health issues, that as much as we focus on national healthcare strengthening, it's important to also consider how countries can cooperate, especially from developing to developed countries. And it's not just about funding, it's also about the experience. So we are thinking about, yes, the treatment of children should be considered, especially in countries that can offer the help that is not present in a country that doesn't, but at the same time thinking about how we can cooperate and share experiences between healthcare workforce. So I think it's a step, it's a positive step to take when it comes to treating children as well as those who are in need in different countries that can offer it. And at the same time, it's an opportunity to make the necessary change on a national level when the populations who are being treated come back to their countries.
Okay, thank you so much, Omnia. So now we go to the second question. How could we develop anti-racism strategies in medical schools and healthcare environments? Would anyone like to address this question? Barnabas, would you like?
Oh. If I may comment. Oh, okay, sorry.
Yeah.
Sorry.
So I think Dr. Osahon and Dr. Rispah have shared some thoughts along that line, so I'll defer to them.
Okay, so we'll go to Dr. Osahon.
Yes, thank you very much. I wanted to defer to Rispah, but let me just say that with respect to the development of anti-racist agenda within the medical institutions, I think the first point is to, again, create a movement in the direction of ensuring that such, an agenda is in place within the medical curriculum, because like we've heard from Omnia, if you look at, if you do a cross-country evaluation or even cross-continental evaluation, you find out that a lot of these, critical issues, including racism in global health, is not adequately provided for in the medical curriculum. So people don't get to have some level of introduction to it until much later in life. when perhaps they're already, very solidified. So we need to be able to not only create awareness within the medical institutions, but also interrogate the medical curriculum, to, make sure that it's appropriately provided for. And of course, also, ensures that even the relationships in terms of the recruitment policies, for medical institutions are devoid of some of these, racist agenda. Because again, at the level of admissions, at the level of admissions, at the level of, the career progressions along the medical, line, you find out that a lot of these tendencies could also inhibit the potentials of the students. So all of that will need to be taken holistically. First, like I said, and placing it in the medical curriculum, creating the needed awareness even amongst the students, and then breaking down those barriers, including, discriminatory tendencies at the level of admission of students, at the level of, teaching, the teaching faculty, the impartition of knowledge, the relationship between the teachers and of course the students, because all of this can create barriers. And of course, ensuring that there is that level of, equitable, distribution, fair distribution within each class, in terms of, protecting appropriately the marginalized and vulnerable populations, so that there's some level of fair representation and not over dominance of one group over the other. So I think this is very important. Then at the level of the health space, I've already talked preeminently about that. And that is where the WMA, World Medical Association, has been doing a lot over the decades. I talked about the various policies, the various principles of medical ethics, including even on medical research. For instance, we have the Declaration of Helsinki, that preeminently, enunciates the need for equitable representation in ethically conducted trials, clinical trials, rather than the abuse of marginalized and vulnerable populations and treating them, in all sorts of forms in the name of conducting research. So the WMA has really done a lot in that respect. But I think with this, with respect to the medical education, those ideas I shared could be, of course, explored to, of course, break down these barriers at that level. Thank you.
Thank you. Thank you, Dr. Osahon. And Rispah, would you like to answer this question as well?
Yeah, sure. Not going to take so much time because I think Barnabas had already touched on it earlier, and of course we've just heard from Dr. Enabulele. So I think what I wanted to say was really around research and academia, and the really looking at the nexus for medical school and for research and academia. So one of the challenges that you find in terms of how research and academia is designed is because of what we consider, first of all, as evidence. What is evidence? It's kind of very traditional scope in terms of what we say. This is what evidence is. This is scientifically sound. This is what we agree upon. But I think actually we need to think back, because there's actually quite a wealth of evidence that is available from our historical context, even within Africa. You look at our historical perspectives, we had people being treated, people getting well, there's so much history you have there that is not necessarily explored or even prioritized to be explored. And you find from different perspectives, different countries, they've had those experiences, which are often shunned, and sometimes even our history is not even, we don't even own our history. So for instance, we'll look at where we can even access this information so that you can put it in the medical curriculum is actually perhaps somewhere in another country, housed in a museum, or it's housed in a docket somewhere. And I think that's where, when we talk about even merging the relationship between high-income countries and low-income countries or middle-income countries, there needs to be that honest conversation about, uncovering all the things that happen, because there is a lot of things that happen that will actually explain a lot of the reasons why we're in the situation we're in, and even the way our health systems are designed, and therefore also the way our medical schools, deliver medical curriculums. And so I think that's something that I just wanted to point out, because I think even the way research and academia, we share information or we quantify the evidence, it's inherently rooted even in a very hierarchical display, and that's, it already disadvantages people from Africa who don't have access to getting into those journals or, all those things. I mean, like, I won't go on about them. I think I'm seeing Barnabas nodding, so I think I hope he agrees with me, but that's kind of what I wanted to mention.
Thank you so much, Dr. Rispah. We're just going to have one more question because we're running out of time and we don't want to cross the time of the webinar, but also feel free to use the power of social media and tweet your questions, tagging our speakers, and I'm sure that they're going to answer your questions. So the last question we're going to have is, to what extent do you believe incorporation of digital technology will help or hinder achieving racial equity and other forms of discrimination? Would anyone like to answer this question? Manon?
Yes, thank you. I think technology in itself will never fight racism or support racism. I think the question is always by whom is it used and who has ownership of the technology project being implemented. I think we all know those endless examples where missions to Africa bring in all these technologies or material that we have used in high income countries, we are done using, and we donate them to low and middle income countries with a flair of we're doing something good, and then there's no follow-up, and then those machines are just rusting somewhere outside in a courtyard. Like, of course, that kind of way of introducing technology is never gonna be sustainable. It's never gonna aid fighting racism. Is also never going to be supportive for improving healthcare systems. I do think that there are, however, examples where technology has been used in a much more useful way. Maybe not an example that relates directly to healthcare, but I remember when I was doing an elective in Kenya, I was very impressed by the, I think it's called the M-Pesa system, where you can actually transfer money using thank you. Using your mobile phone to pay money to friends or even healthcare providers, pay school fees. And I feel like that is a perfect example of local ownership of technology where it is used by Kenyans to solve a Kenyan problem in a Kenyan way. And I know examples of in Palestine where they worked with mothers on how to reach them with text messages about their next appointment for the immunization of their children, and they really worked with them on over 2 or 3 years to understand, like, do we need to send it 1 day in advance, 2 days in advance, like how many times do you want to hear it? And I think if the ownership is shared or completely given to the populations that will use the technology, then I do think that technology can help in fighting racism and achieve social justice.
Thank you so much, Manon. So now we've reached the end of our webinar. A huge thank you to our amazing speakers who gave us hope and showed us how we can actually challenge the status quo, and showed us that we still need to do lots to change our reality and to address this issue in global health. To take this chance, just one last message from each speaker, just highlighting one important take-home message you want our participants to keep in mind when it comes to racial justice in global health. So we'll start with Dr. Flavia Senkubuge.
Thanks, Dr. Batul. Mine is really, let's create the structure, develop the policies, and put the right people in. You can't put the right person in a broken structure, it will break that person. So let's, create the structures and make sure that we have a structure that will ensure that we achieve our desired goal. Thank you.
Thank you. Dr. Walumbe.
Thanks so much for this opportunity and a chance to speak amongst very esteemed panelists. I think I just want to say that one of the things that's going to be really important as we move forward is really looking back. First of all, looking back at what happened, looking back at how we've progressed, looking back at why we are where we are. And then the second thing we need to do in terms of moving forward is also to look at our mindset. Because that's going to be a really important consideration, because that's a mindset for everyone. That's a mindset for you and me. That's a mindset for our government. That's a mindset for policymakers. And that's a mindset shift that's going to also be required by global health leaders from different institutions. So I think if we look back, look at our history, and then also acknowledge what happened, and then think about our mindset and how we can shift that process, that will then start to change the implications, what that has for policy, what that has for even African countries sustaining their own growth and being able to take power and be resilient for themselves. So that would be my parting message. Thank you.
Dr. Enabulele.
Yeah, thank you very much. Once again, thanks to the organizers. The World Medical Association acknowledges racism in medicine as a social determinant of health that has created lots of health inequities and disparities in health outcomes. And the World Medical Association believes very strongly that it can be addressed by accepting first the reality of this public health body, and then in place, policies and practices that will create an inclusive environment, and also, promote, universal health coverage, which also is fundamental in driving equitable access to healthcare. Importantly, there is need to promote the medical ethical principles of the World Medical Association, the Declaration of Geneva, the Declaration of Helsinki, and of course, the International Code of Medical Ethics, and also promote more research in this very important area. So I think once we enforce and in place, anti-racist policies and practices, and create some level of open, transparent, transactions, a lot of things can be addressed, at the end of the day. Thank you very much for the opportunity.
Thank you, Dr. Enabulele. And now, Dr. Al-Umrani.
Yes, so my take-home message would be one that was mentioned by one of the panelists, is to be persistent and to have the uncomfortable conversations. I also want to highlight that as young medical students, we are very active and we're passionate about the causes, especially when it comes to health equity and racial justice, but we cannot do it on our own. We want the faculties, governments, decision makers to work together with us, especially when we're looking at our education. Medical education is very difficult to change, but it can happen, especially with critical issues like health equity. So it's both, and one important thing is to always be persistent and not give up, especially when it comes to causes that affect how we become as future healthcare professionals.
Thank you, Umnia. Dr. Alayande.
Thank you so much for this privilege. Racism is pandemic and its roots run deep. And until we begin to unearth those roots, we're not going to go too far. And it's about relationship. Racism is not something that's happening way out there. We need to sit down and really reflect and think about how we are somehow or the other pushing racist agendas, even if we're standing on this side. So being anti-racist is deliberate, it's an action. It is about what you do. So my encouragement is that we should keep thinking about it and acting on it. Thank you.
Thank you. Dr. Manon?
I think my take-home message is predominantly for my peers in high-income countries. I would like to say, please think well before you enter global health. If you want to go into global health to become a hero to solve HIV, I'm not really sure that this is your place. I think please come into global health if you are genuine about achieving equity, and if you are ready to have the difficult conversations that we thought about, if you're ready to see the shared past that we have in colonialism and to work towards addressing all the effects, and if you're ready to accept a system where with a lot of power dynamics and with a lot of effects of colonialism in every daily practice that you do. And I think if you are ready to accept that, and if you are ready to work in such an environment, please join us, but think well before you do.
Thank you, Manon. And the final words for Dr. Park.
Okay, thank you. Yeah, the Durban Declaration was 20 years ago. We all agree what the right thing to do is, right? But look where we are now. There's been a resurgence of racism. It's because it speaks to the current system. The status quo favors persistent and actually worsening racism. So I think, if anything, the message for me was we need sustained effort to dismantle the system and we'll do it together. So thank you.
Thank you, Dr. Park. Thank you, everyone, for joining us. And we've reached the end of our panel. Thanks a lot for our speakers and for the participants as well. Thank you.
Thank you.
Thank you. Goodbye.